Hello, everyone. Welcome to the Brown Surgery Podcast. I'm your host, Kenneth Lynch. For those of you that do not know me, I'm a PhD educator and nurse practitioner by training. The focus of this podcast is to span both clinical and educational fundamentals and turn everyday topics into interesting discussions that can benefit students, residents, and faculty alike. Today, we're going to continue our discussion on the role of the surgical scientist. Last week, we spoke to Dr. Dahi Heffernan on the topic, and today I'd like to welcome Dr. Sean Monaghan to the podcast to continue this discussion. Dr. Monaghan is an assistant professor of surgery and NIH-funded researcher here at Brown. As many of you know, Sean trained here with us as a resident, doing 2 years of basic science research in between his clinical years. He then went on to his fellowship in surgical critical care at Beth Israel Deaconess in Massachusetts before coming back to us as a faculty member. Sean now has a unique role as one of our trauma ACS critical care surgeons. When he's not taking call and operating, he oversees a robust basic science lab that focuses on RNA biology, specifically alternative RNA splicing in critical illness. A lot of his current work revolves around managing large RNA sequence and data sets from patients. Because of this, we thought it would be good to hear his experience with going into the lab during residency and how he balances both a clinical and research career. All right, so I'd like to welcome Dr. Sean Monaghan to the podcast today.
Hi, Kenny.
Jumping right into it, Sean, there's a lot of reasons residents go into the lab to do research years. It's either fellowship-driven or for professional development purposes. It's not too often that folks do trauma and research, so I think it'd be interesting if you'd give us an idea of what were some of the deciding factors that made you go into the lab during your surgical training.
Yeah, I went into the lab because I think I just wanted to have a little bit more experience and exposure to research in general. I did some research in medical school, but it was mostly clinical, and I really wanted to look at some basic science aspects as well. And it was definitely my mentor in medical school actually recommended my research mentor here at Brown as one of the probably factors in making me decide to come here as a resident. And I think I had a really good experience when I decided to go in, and that kind of propelled me into picking a career in trauma and critical care with a research component as well. I think when deciding to go into the lab, like you mentioned, there's kind of two paths. There's the path of I need to do this because I need to get this fellowship and that's what I want to do with my life, or just kind of a curiosity and trying to become maybe more well-rounded, maybe thinking you might want to take a crack at research, things like that. And I think, at least in surgery, it gives you an opportunity to kind of take a break, sit back, and really learn some new techniques, tricks, skills, and potentially become a more well-rounded clinician as well, because you know how the papers are written, you know how science is done, and then if you're really interested, you can try to do some of that research that can change practice or change how we treat patients.
So yeah, just jumping off of that, I'd like to hear some of your thoughts on postponing residency, the clinical training aspect, and jumping into research years. There's a lot of debate nationally on whether surgery should allow folks to go into the lab after their second year, or should they do it after their third year. Surgery is the only discipline that offers the lab in between current clinical years. Most other disciplines go on to do lab years after their residency. I don't know what your thoughts are on this, if you could expand on that. Did you find it difficult to halt your clinical practice to go into the lab and then come back out and jump into clinical?
Yeah, I think doing it after second year, at least in my opinion, is the ideal time. Your clinical practice as a first and second year is intense, but it's not intense usually in terms of an operative experience. And I think having those 3 years after the research time to really operate and get hone that skill is very important. There's also the added benefit of if you have 3 years to finish up your work from the lab, it can accelerate or enhance your applications for fellowship. If you come in after your third year, you're starting your third year, then some fellowships are applying right in the beginning of your fourth year. So you only have 1 year to kind of wrap up loose ends from work that you did the previous 2 years. And that can sometimes be difficult. There's also the idea that, a lot of specialties do research in their fellowship years. And, I'm a trauma critical care surgeon. Kind of the corollary to that in medicine is pulmonary critical care. And their fellows do a year of research as part of their 3-year fellowship. And that, if you're having a career where you actually do a lot of research, can actually be a lot more useful because you translate right into your faculty position, whereas for us as surgeons, we have to kind of bob and weave a little bit as we finish our clinical training to continue that research track, and that can be a little bit difficult, but not impossible.
So just fast forwarding to where are at now, I think you have a pretty unique practice. What's a day in your life look like?
Yeah, so it depends on the week. I have a job where I'm very fortunate, where I have a lot of partners in the trauma and critical care and acute care surgery division who, cover weeks at a time like I do. And I have a job where I do 2 weeks of clinical work followed by 2 weeks of research. And that's really helpful from the research perspective because I know I'm not going to be interrupted by emergencies or other things. And allows me to really sit down and think and get that research work done. That being said, one of the downsides of being a clinician and a researcher is that you're competing against people who are researchers 24/7. So sometimes, there are times where meetings or other events do kind of sneak into those clinical weeks as well. And, sometimes clinical things sneak into the research weeks, but I try to keep a pretty strict divide and balance of 50-50, 2 weeks on of research and 2 weeks of clinical.
Would you say that your schedule is common or uncommon for a surgical scientist? If some of our residents were thinking about going into the lab and kind of thinking about what their career ultimately would be, how common would you say your practice is?
I think a lot of it depends on the specialty and the center you're at. I don't think this is a 50-50 split like this. I don't think it's common for someone who's a general surgeon in a community hospital doing, gallbladder hernias, breast surgery, colonoscopies, things like that. However, at a large academic center, and depending on the specialty, obviously, you might see schedules like this. Trauma critical care is one that it happens in. I've heard of surgeons who have this kind of schedule at large transplant centers. Sometimes it occurs in pediatric surgery. And then some of the other more operative intense specialties, it might not be as easy to do.
When you talk about balance, how difficult is it for you to maintain both your clinical practice and a research lab and bounce in between the two?
Sometimes it's harder than others. But at the same time, I think the balance is good. After 2 weeks of research, sometimes I like showing up on Monday and taking out a few gallbladders or seeing a patient in the ICU. And sometimes also after a long week of call, going into the lab the next week and knowing that I can sit and read and think about something differently is also, kind of important to the balance. So I think they play off each other pretty well.
I asked Heffern this question. I'd be curious to your thoughts on it. What would you say to those who say that the triple threat doesn't exist in surgery anymore?
The classic triple threat of teaching, research, and clinical practice is very tough to do these days. And I think it's an expansion of the requirements of all the facets. It's a lot harder to get an IRB study approved, or it's a lot harder to, back in the day, there wasn't as much emphasis on education, and it was kind of like you were given that task and you kind of just did the best you could. But now there's tons of requirements that the ACGME, appropriately has out there for this. And then the same thing goes with clinical practice. I mean, you hear about the time when residents operated and the attending surgeon was in their office and called in and saw if there was a problem, and they weren't even in the OR. Whereas now, faculty are in the OR, much longer than they were, say 20 years ago. And again, all of these things I think are important changes and benefits, and they're better for patient care, they're better for research, they're better for education. But I think we haven't expanded the number of hours in the day, and we never will. And I think that's where it's almost impossible to do all three of them at the same time anymore. That being said, that doesn't mean I don't care about education, or I don't care about my clinical practice as much, or I don't care about research as much. It's just I don't think I'd ever be a NIH-funded investigator with a full elective clinical practice and a program director at the same time. I don't think something like that is possible anymore.
Just expanding a little bit, you mentioned the IRB there. Getting into research in general can be a daunting task, let alone spending 2 years in the lab like you did. And being someone who successfully completed lab years and residency and has a successful clinical career now with your research lab, for those residents who are, thinking about dipping their toes in the water, so to speak, and get involved in the research arena or getting ready to put an idea into motion, what tips would you give them? Any resources for grant writing, for getting IRBs started?
Yeah, I mean, I think, you spoke about the IRB. I think sometimes when you take the tack that the IRB is against you is the wrong tack to take. One thing to always keep in mind is that the IRB is there to help you, and they're there to keep you safe and keep the research you're doing to be correct. They kind of have a responsibility for the institution to ensure that the research we do here is appropriate and doesn't, break any rules put out by different government agencies. And it may seem like a meaningless checkbox or a meaningless answer, but it's really just to kind of keep everyone on the same page and everyone safe. So I would definitely use, the IRB as a resource, not as kind of the enemy. The other way to do it is to like ask people who've done that before. Lots of IRB forms are templated, and you just need to write the right answer and do the right thing, and it's a lot easier to get through. In terms of grant funding, there's lots of organizations that fund, surgeon residents for research. They have funding opportunities. The key is knowing you're going to go into the lab as early as possible. I think our program has this benefit of not everyone has to go into the lab, which I see as a huge benefit because we attract a diverse set of people, people who might not want to go into the lab. But because not everyone goes into the lab, sometimes deciding whether you want to go in the lab gets delayed a little bit. And so sometimes those grants are not, you can't apply to them because deadline's already passed. And just, most of those grants are due the summer after your intern year, or the fall after your intern year to start after that second year when you start in the lab. So just, that's something to keep in mind. And, the societies you can think of are things like the American College of Surgeons, Society of University Surgeons, Shock Society, Surgical Infection Society. They all have varying grants of different amounts. The other thing to keep in mind is our department also has grant funding available for residents to support them in the lab as well. One is through the NIH, and one is through what we call the Versace Fellowship. So those are available as well.
For those residents right now who are considering, there are residents right now trying to make a decision whether or not they should go into the lab or not. And you mentioned professional development and fellowship reasons behind it. But for those considering a career in surgical research or thinking about going into the lab, what would be your advice to those residents?
It's kind of similar to advice I give to medical students thinking about going into surgery. Research isn't something that's easy. There's a lot of failures. It takes a lot of time and effort. And, I wouldn't do research as a long-term career because you think it's the right thing to do. I think you do it because you can't imagine not doing it. Obviously, going to the lab for 2 years, you can do that, to get some papers and publications so you get the best fellowship you want. But, if you're really thinking about a long-term career with it, you got to make sure it's something that you can't imagine not doing rather than something that you feel like you should do because you did 2 years in the lab, well, I should do this. But that's not always the case. It's okay to say, yeah, I learned a lot. I'm a better clinician. I'm a better scientist because of it. But having my own basic science lab is not definitely for me.
I think in terms of, and I know you've spoken about this in the past too, I think a decision that plays into it too is like putting their career on hold for 2 years or foregoing 2 years of potential income that they would have made if they graduated 2 years sooner.
Right.
What would be your advice in terms of that decision making?
Yeah, I think, there's definitely, the money issue is definitely key. You're delaying a pretty significant surgeon salary for 2 years. And again, some of it comes down to job satisfaction. Some of it comes down to making a sacrifice to get the best fellowship. You get the best fellowship, you get a better job. There's all kinds of those things that factor into it. Some just real solutions or real ideas that I've experienced or had the opportunity to look at is, other potential resources. So there is the National Institute of Health Loan Repayment Program, which will pay up to 50% of your loans each year. That's a recent increase. It used to be $35,000 a year. They also pay the taxes on it, and that's if you're doing clinically oriented research. Because I have 50% time, I'm able to do that, and that's kind of a way I could think about how I sacrificed 2 years of income, but my loans are getting paid for partly by the NIH. The other thing is, it's another way to kind of show value and your worth for a department. Many departments of surgery are looking for people who are doing research. Not every department can afford to support a new surgeon to try to set up a lab and things like that, but there are lots of departments that are looking for it, and there's that is an added benefit. You bring something different to the table, and you might get a better job than you would have if you didn't have research. And then finally, one thing that I've been working on is kind of the entrepreneurial side, or, we have some intellectual property that we've filed with the hospital, and there's a patent associated with it, and the potential to turn that into something else is also an opportunity that really only exists if you're doing research or you know how to do research, because it's kind of the first step in that process. Even if you are going to you're going to design the new DeBakey forceps, the better DeBakey forceps, you're going to have to know how to do research to prove that it's better, and that's kind of where you can get that foundation. So it may not be, a basic science intellectual property like mine is, but any intellectual property, you kind of have that research background to get the first steps through.
Yeah, it's definitely a valuable tool to have, and no matter where you work, I think residents realize that they're going to be a part of some type of research along the way. So, well, I just want to thank you for sitting down with us today. I know a lot of residents think about these and these career decisions, and so a lot of this information you shared with us today is going to be helpful for them to make those decisions. So I appreciate it.
Thank you.
So this concludes our two-part series on exploring a career as a surgical scientist. I hope the discussions held with both Drs. Dahi Heffernan and Sean Monaghan were enlightening. I think both were able to provide insight into the decision process of entering the lab as a resident, the resources available to researchers, and how to balance a clinical career with research as well as family. Stay tuned next week where we continue our research theme and speak to former Brown faculty member Dr. Eric Benoit on using mortality as an outcomes variable in clinical research. Also in the month of April, we will kick off our Chief Resident Podcast project here at Brown, which we are really excited about. Some of the topics we will cover include narrative surgery, crush versus compartment syndrome, esophageal perforations, and HIPEC management. So stay tuned for those, and I'm looking forward to having you back with us in the next episode.